Hello, Myo family. Today I have chosen kind of a fiery topic to talk about, which is going to be sleep apnea and stuff related to sleep apnea. The reason that I chose this to talk about today is because yesterday I had the luxury of meeting a beautiful human, a woman who had been diagnosed with severe sleep apnea and who essentially had been told, okay, you have sleep apnea, here, wear a CPAP, and bye-bye, next, please, So she reached out to me really at kind of the end of the desperation highway. And so throughout my time with her and the opportunity to educate her, I just get so frustrated and disheartened and saddened that so many people, and you guys, I only get to meet just a small percentage of you, a small portion of you. So I know that there are tons and tons of people who get told one thing, hey, here's your diagnosis, enjoy it, type of thing. So I've made some notes here on things that I want to talk about, but the biggest takeaway really from my time meeting her yesterday was, being in her 60s, she has a lot of life left to live. And feeling like you get told you have, sleep apnea, and you're like, okay, are there any options? And that I really feel drawn to continue to share. I talk about this stuff a lot, but if you're new to me, maybe you've never heard it, or perhaps you haven't just felt the need to hear that message. Like maybe you didn't know you had sleep apnea concerns. Maybe you just think your sleep is like poop and that's just how it's going to be, which generally isn't the correct case as well. So I just want to talk about a couple things, because in this conversation with this lady yesterday, like her mind just kept being blown when I would educate her on something and she would say, I had no idea, or I didn't know this was a concern. So the biggest thing is, you guys, as our face develops, we have obviously an ideal, when the bones of the face develop forward, and they get big enough. And so that I always use Dr. Stephen Lynn's explanation of the stadium. You cannot put all the chairs in your stadium if your stadium is too small, okay? So when I'm meeting somebody and they're saying, hey, I have obstructive sleep apnea, it's been diagnosed, I just want to see if there's something you can help me with because I feel like poop. And my CPAP just is not, it's not the magic pill that I'm sold it to be, And so when I meet people, I look at the facial structure. I look at how narrow the arch is. I look at the dental crowding, all of that stuff, because when somebody comes to me and they say, I have sleep apnea, it's like, okay, what are our options? What's the concern here? What's the myofunctional impairment? Where can I help? Because I am not the unicorn with a golden horn that's just going to solve all problems for you. So just because you get a sleep apnea diagnosis, it's like, now what? Okay. So this particular person is using a CPAP, and had some difficulty, being successful with the CPAP because like the mask was too heavy on the face. And now just even having the nasal pillows, she feels like her mouth is open. So she's still mouth breathing, so that's a myofunctional impairment. That's something that I work on, but it's like big picture. Okay. So just because you get a sleep apnea diagnosis doesn't mean that there's no options. And that's what I just really wanted to start talking about is, what does this mean? Is that the only option for you is to just wear a machine the rest of your life? So this lady being in her 60s, is just feeling like, is this it? Now, myofunctional therapy is a great adjunctive therapy. I never want somebody who has severe apnea to think that I'm going to be that golden unicorn. but I'm going to help them make improvements in the rest of their impairment. In this case, it was swallowing, it's tongue posture, it's mouth posture, that kind of stuff. But you guys, first, let me back up, okay? So let's talk sleep apnea. All sleep studies are not the same. And what I mean, this particular lady had been diagnosed, okay? But some people don't even get a diagnosis because they're told, no, you're fine, or you're not bad enough, and that kind of stuff. So one thing that a lot of people don't know about, and I didn't learn about this until I became a member of the AAPMD, which is the American Academy of Physiological Medicine and Dentistry. So that's an organization that I'm part of, and I do a lot of continuing ed with, and it's literally doctors and dentists who are working to educate people like you. It's working to get rid of that silo mentality that says, nope, this is just my area over here. I don't touch that. It's working to help dentists move beyond thinking their only problem is the teeth. I have met many, many dentists that say, not my monkey, not my circus. I don't have to worry about anything but whether I'm going to put a crown on this tooth, which is not true, by the way. And so the AAPMD, we work tirelessly to try and bring awareness to the medical work, like trying to help bind the two together, okay? So what I learned in a conference a couple years ago, and it has reared its ugly head so many times, is that not all sleep studies are the same. So there is something literally in a sleep study, and my note here says, hypopnea scoring rules implemented in 2013. So there's two different scoring rules that currently exist that cause confusion. One is called a 1A, one is called a 1B. 1A, it looks like it's the recommended rule. There's several things that, fall under that, and I'm not going to go into that here, but then there's also a 1B. The tricky thing is here, you guys, is that Medicare only recognizes a 1B. So that really hits home personally for me because my daughter, my sweet Taylor, is 25. She has upper airway resistance syndrome and she has sleep apnea on her back. So it's positional. So when she rolls to her side, of course, they average it out and they say, no, you don't have sleep apnea. So she comes in 1/100th of a point below being diagnosed with sleep apnea. But the interesting thing is that if she was on Medicare, they would diagnose her apnea. And that was from one of my airway providers who we went to saying, okay, what do we do? Here's this 25-year-old. She sleeps terrible, has nightmares all night. She has the night sweats and sits upright. And like you look at her sleep study and she is just up and down all night. And she has insomnia because the body is saying, hey, friend, you're awake. And guess what? When you're awake, you're alive. So let's just watch another episode of, King of Queens. And so in my daughter's case, it has been very, very tricky to maneuver this process because the traditional model, medical model, I guess, says, oh, she's fine. But if she was on Medicare, they would diagnose it. So there's definitely a difference between 1A, 1B. So I ruffle a lot of feathers when I meet clients and I say, okay, so you had a sleep study and you were told you were fine. The problem is you're not fine. Something is going on. Now, there are other sleep disordered or sleep conditions that are not only apneas. You've got central apnea, but you also can have narcolepsy. There's other things. So it's not only just one or nothing. But if you've had a sleep study and you have been told you're fine, but you still feel like a bag of dog poop, then you have to fight and advocate for yourself. And sometimes that means inquiring to the person who does your sleep study, to the person who reads it and interprets it, about the Rule A, 1A, 1B. It looks like the biggest difference for Rule 1A is that no oxygen desat is required. And so again, I'm not the person reading your polysomnogram, but it is a helpful thing that I always help my clients, like put that feather in your hat. Like it's not always just this or that. Okay. So not all sleep studies are the same. So that is one thing just to think about and ask, because in my conferences, I have participated in case studies where we're looking at different clients this instance where they were told that they were just fine, but it was calculated wrong, not using the right rule. And then when they recalculate it with the other rule, oh, bada bing, that person has severe apnea. So definitely something to think about. So I did want to touch on that. Now back to the lady that I was talking about. So she has been given a CPAP, okay? And it's just not doing well for her. It's doing decent, but not fantastic. She had already tried a mandibular advancement device. That wasn't great. But a CPAP is not your only option. And so what I really was saddened to learn with her is that, you know, by looking at her facial structure, seeing that she was high and narrow, she was really crowded, she has a space issue. You've heard me talk about Dr. Felix Liao's book all the time, 6 Foot Tiger, 3 Foot Cage. That's a space issue. And it also tells me that's an airway issue, because if the bones of the face don't develop correctly forward, it's evidenced inside you guys. So I could look at her, just look at her pictures and say, we have a problem here. But the reason I was so saddened is because I said, has anybody ever said to you, what about doing some airway ortho? You know, and most people think about airway ortho as braces, and that's not it. Yeah, that's a piece of the process after the fact, because, you know, if they expand the bones of the face, you now have more room in your stadium. So you're going to have to rearrange those chairs and, to get the teeth back together, you know, nice, cosmetically looking. But that's not the whole point. The whole point with airway ortho is to fix the space, to bring the bones forward, to create more room for your tongue. When the mandible when the maxilla is enlarged, the mandible will come up kind of like a lid on the box. So the maxilla will be the lid on the box. The mandible will enlarge to kind of fill that space. And when it does that, you guys, it brings the tongue, it brings the tonsils, the tonsil pillars, it brings the airway with it. So you're going to get an enlargement in airway volume, okay? And so this lady's eyeballs were this big when she was saying, that's an option for me. And so it really is. So if you find yourself having been diagnosed with sleep apnea, has somebody helped you with that conversation, okay? Which leads me to the next thing of, okay, where do you go for these conversations? It's very hard. And that's why I work tirelessly to have these unpopular conversations, if you will, because there's a doctor somewhere that if they were watching this, I'm pissing them off, and I'm fine with that. But let's talk about avoiding extremes. Another one of my clients recently, we were talking about the sleep. So she had an office sleep, a take-home sleep study. So like the watch pad or something, which you guys it's a great screening tool, but it is not the diagnosis that some people need. Sometimes you need a sleep study in a lab where they monitor brain activity, limb movement, that kind of stuff. So what you do at home is basically just kind of a screening to say, hey, yeah, there's concerns. I get that they diagnose from those, and I'm not saying whether that's neither here nor there. It's just that when, like in this particular case, my client had an at-home study, and then the doctor was selling her an appliance. And so it was, interestingly enough, I said, okay, so the doctor has something to sell you and to help you with this. And my client said, yeah. And I said, well, how much is that? And I don't remember what she told me. But then my client said, but here's the kicker. The doctor told me, I'm so concerned about how bad your sleep study was and how bad your oxygen desaturation was that I'm going to give you a $2,000 discount on this appliance. Red flag. Red flag. So why do I have a red flag? First of all, I told my client, if your sleep study was that bad that the doctor is so concerned about it that she has to get you immediately into this appliance, that she's going to discount $2,000. If your sleep study was that bad and your oxygen desaturation was that bad, this doctor has no business giving you an appliance when you have not been sent for a sleep study. Nothing was diagnosed, okay? That's the tricky thing and why I was floored, because the doctor can't sit and tell you, hey, I think you have this, this, and this. The person who reads your polysomnogram has to diagnose. No matter what. People just can't say, hey, you have apnea. I meet so many people who have been told that they have sleep apnea, but nobody's ever tested it, okay? And so in this instance, I feel wholeheartedly like this doctor was being negligent in saying, I'm so concerned about how bad everything is for you. Hey, let me sell you this appliance, okay? And I'm gonna discount it $2,000. So my client went from having that to then finding a sleep doctor who told her that the only way to treat sleep apnea is with a CPAP. Now, I'm not arguing that that's not the gold standard, okay? That is the Cadillac Mac Daddy. Some people don't do well with that. And quite frankly, if I was to be diagnosed with sleep apnea today, there's about a 0% chance that I would ever want to have a Band-Aid on a bullet wound. I want to try and fix what is wrong. And so there's a reason, you guys, that compliance is less than 40%. But the takeaway message here is that my client went from this extreme of one doctor saying, oh my gosh, you know, Chicken Little, the ceiling's falling, the sky is falling, to this other doctor who said the sleep is only, or a CPAP is the only way that you treat sleep apnea. I don't remember if that doctor said she had sleep apnea or not. So that's the whole gray thing, is my client doesn't even know whether she does, yay or nay. But that doctor made an incredibly powerful statement that said something like this: there is no place in sleep medicine for dentistry. And again, going back to the AAPMD, I don't support that. I don't believe that. And if you have a doctor who has that kind of closed mind, silo type of thinking, I think it's really helpful to hear from somebody like me that says maybe you need to expand your horizons a little bit. Maybe you need to reach out to somebody who's in the AAPMD, because I can guarantee you go find a sleep doctor who's in the AAPMD, they work hand in hand with somebody like me. They work hand in hand with somebody like an orthodontist and a dentist, that kind of stuff. We all collaborate and work together because we know we are brilliant enough to have worked past that silo mentality. There is nothing inside your body that says, hey, this is just for the cardiac doctor, and this is just for the diabetes doctor, and oh, this over here is just for the stroke doctor. No. On the inside, you are just all one big unit, okay? So I guess the biggest thing there is avoid extremes. If you go to somebody and they say the only way you can fix it is boom, are there other options, okay? If you go to a doctor who says, oh my God, you're so bad, your sleeping is so bad, and blah, 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 here, let me sell you something. Can we further support that? Can you further say, do I have a sleep study? Has this been diagnosed? That kind of stuff. And then I think really I'll leave you with, go to the AAPMD website, go research, learn more about airway ortho. I have a ton of information on my website. I talk a lot about it. Airway ortho is not your traditional ortho. And so a lot of people's eyes glaze over when we talk about that, because they're like, oh, hell no, I am not getting braces at my age. It's not a tooth beautician thing. It's not a cosmetic thing. It's an airway, and it's a face and a developmental thing. So we as a society are having flatter faces. We're having more problems with craniofacial development because we're not doing things like nasal breathing, which puts an expansive force on the face. We're not doing things like eating food. If you're a parent and you have a kiddo, helping your kid chew and understand the importance of chewing, using those muscles. Anytime you're chewing, that's putting an expansive force on the face. Stop using pureed baby food. Stop drinking applesauce out of a pouch. Stop cooking food to death. Stop cutting it up into little tiny pieces because your kiddo needs to chew. But that's why as a society, we're starting to see flatter faces, more recessed chins, our face going backward, which only means an airway crisis. So it's getting worse. But there's a lot of resources out there. I think it's just opening your mind, dropping into that rabbit hole, reaching out to somebody like me who will help you. So I think I will end on that. Like, what do you do if I'm talking to you, if you're feeling this on your heart? The best place to start is with somebody like me. You need a comprehensive assessment so I can look at what's going on, and then determine what else we need. Do you have a tongue tie? I don't care if you're 60 or 70. If you have a tongue tie, we need to address that, because you cannot have the tongue up, supporting the airway, completely in contact with the roof of the mouth. You can't have that if you have a tongue tie. You're not swallowing correctly if you have a tongue tie. I can guarantee that. And I know that's a powerful statement. But just because of whatever age you are, you do not have to be resigned to the fact that there's nothing going on, because I can guarantee you that this client yesterday was floored when I say, hey, you have a ton of crowding in your mouth. I can see where your tongue does not have space for anything. And so it is an obstruction. If it's tied down, yes, that can be part of it. But the bigger picture, you guys, is that craniofacial development. So drop into that rabbit hole, go research, find all the things, ask all the questions, fight for yourself. But the best place to start is somebody like me, a myofunctional therapist who has specialized in airway and sleep, that kind of stuff, because I think it will make all the difference. So thank you for hearing me out and allowing me to get ramble and get fired up about sleep stuff, because it's so hard. And I know many of you guys feel like your diagnosis is just like a stop sign, the end of the road. Do not pass go, do not collect $200. And that's just not the case. So I hope that's helpful. If it is, share this with somebody who needs to hear it, because that's the best way to pay it forward, is to share important information with somebody else. So have a beautiful day. Thanks for watching, and I'll be back next time with another hot topic. Bye for now.